This is Ruth Iverson. I've made this PowerPoint to go over oxygen delivery devices. Please read the required text as noted in your RN-SG 1216 syllabus. Practice application of oxygen delivery devices and discuss safety and use with a peer in the Skills Lab. If you have any questions, please see an instructor in the Skills Lab for clarification. This PowerPoint lecture is designed to help the student understand safety, equipment, and procedures associated with the delivery of oxygen to patients. The concept of gas exchange will be discussed at greater length and depth in the lecture component of your courses. Safety is important in the delivery of oxygen and will be discussed as it pertains to the acute care and home setting. The purpose and administration of oxygen therapy will be discussed, as well as delegation and nursing considerations. Equipment for the delivery of oxygen, such as sources, rate restrictors, and delivery devices will be discussed. Nursing considerations specific to these devices will be reviewed. In addition to the delivery devices, airway management devices such as nasal and oral pharyngeal airways, incentive spirometry, bag valve mask devices or AMBU bags, and pulse oximetry will be discussed. Patients with impaired gas exchange often require supplemental oxygen. This may be a short-term therapy, like during surgery and recovery, or may be used continually for those with chronic respiratory conditions such as chronic obstructive pulmonary disease, or COPD. Oxygen therapy is beneficial but can have dangerous effects if given inappropriately or in an unsafe manner. You will study in greater depth about the purpose and indications for its use in your gas exchange lectures. You should have an understanding of how oxygen is transported and used in the body from your A&P courses. A review may be helpful before studying gas exchange. Oxygen is a medication and thus requires an order from a healthcare provider, and all of the rights of medication safety must be followed. These rights will be discussed when we review medication administration in Week 4. In addition, patient assessment and safety criteria must be observed. An assessment of the patient's respiratory status is needed before, during, and after oxygen use. You are learning the criteria for this assessment and should be practicing the techniques in the Skills Lab. When assessing patients requiring supplemental oxygen, the nurse should be alert to signs and symptoms of hypoxia. Anxiety, apprehension, and changes in behavior are early symptoms. The nurse should be alert for poor concentration, confusion, sleepiness, or decreased level of consciousness. Increases in heart and respiratory rate and regularity may be noted. Respiratory assessment findings may also include labored breathing, dyspnea, and the use of accessory muscles. Skin and mucosal changes may include pallor and/or cyanosis. Adventitious sounds may be noted upon auscultation. You will learn more advanced assessments and monitoring of patients on oxygen therapy as you study gas exchange and impairment-associated exemplars. A pulse oximeter is a valuable assessment tool as supplemental oxygen is frequently ordered to keep the oxygen saturation above a certain level, typically 90 to 92%. Pulse oximetry will be discussed later in this PowerPoint presentation. A safety assessment of the oxygen equipment should also be made each shift. Adjustment of the oxygen delivery device on the patient's face and obtaining the pulse oximetry reading may be delegated to a nursing assistive person. Assessing the need for oxygen, monitoring the patient, adjusting the flow rate, evaluation of therapy, and patient teaching are all the responsibility of the registered nurse and may not be delegated. As stated before, oxygen is not without risk. Oxygen supports combustion. 3 things are necessary for a fire: heat, oxygen, and fuel. The patient and their surroundings are the fuel, and anything that ignites and continues to burn, such as a spark or flame, is the heat source. A fire needs oxygen from the air to burn, and the use of supplemental oxygen increases the rate at which the fire burns. Oxygen safety guidelines include measures to decrease the risk of combustion. Patients with COPD are at risk for carbon dioxide narcosis. For most people, the accumulation of carbon dioxide levels drive the need to breathe. Patients with COPD develop a tolerance to a higher CO2 level, and hypoxia becomes the stimulus to breathe. High levels of supplemental oxygen decrease the stimulation. Oxygen supplementation should therefore be slow and monitored by arterial blood gases in these patients. You will learn more about this when you study the concept of gas exchange. Oxygen toxicity is another risk of oxygen therapy. Prolonged use at high concentrations can result in inflammatory responses such as pulmonary edema. Concentrations of 50% or usage longer than 24 hours increase the risk. Infection can result from oxygen therapy, especially when humidified or nebulized. Oxygen is drying to the mucosa, and moisture is frequently added to prevent damage. Heated nebulization poses the highest risk of infection. The use of disposable, closed systems are best to prevent infection. Sterile or distilled water should be used and changed out daily or according to facility protocol. In the acute care setting or hospital, oxygen is usually delivered via a permanent system. Oxygen is stored in tanks and delivered by pipes in the wall when activated by a regulator at the bedside. Portable oxygen tanks, called E-cylinders, are used when a patient needing continual supplemental oxygen must be transported to various departments. For home use, oxygen is supplied by various methods. It may be in the form of liquid oxygen, which is easier to store, less expensive, and uses no electricity. It does evaporate continually and must be replaced more often than other methods. Oxygen compressed in cylinders is an option, but is more difficult to store, can be more dangerous, and is costly. An electrical oxygen concentrator or extractor is a method that removes nitrogen from room air and does not require refilling. For those dependent on oxygen, a backup plan for electrical outage is necessary. A concentrator is also available as a portable unit that runs off of rechargeable batteries or electricity. Oxygen conserving devices deliver a pulse of oxygen on inspiration. These devices can either be a pulsed or demand device. The pulse device delivers a burst of oxygen during every or alternating breaths, depending on the prescription. A demand device delivers the oxygen on every breath but is spread out over the length of the patient's inspiration. No oxygen is delivered on expiration. We will now discuss safety guidelines when administering oxygen. In an acute care setting, oxygen and other medical gases are stored and are color-coded. Oxygen is denoted by a green color. Some E-cylinders are silver and green. The plate covering on the head wall in the patient's room is also green or has the word oxygen written in green letters. Medical air is not to be confused with oxygen. Medical air is similar in composition to room air but has no contaminants or oils. It is used for some respiratory therapies and ventilators and is denoted by the color yellow. Oxygen and medical gases have emergency shutoff valves on the wall at various zones throughout the hospital. Nurses should know the location of these valves. The nurse should also be knowledgeable about who is designated to turn off the supply to a specific zone in the event of a fire. This action will affect all patients in that zone and is pre-assigned as part of a hospital fire safety plan, typically to a nurse manager. Care should be taken when using E-cylinders. They should always be stored upright and secured in designated holders to prevent falling over. If knocked over, the compressed gas causes the cylinder to act like a rocket. Tragic accidents have occurred as a result. E-cylinders should be stored away from electrical outlet, sources of heat, and solvents. The cylinders should be inspected for corrosion or rust. Cylinders should be routinely checked to ensure adequate fill, especially those designated for emergency use, such as on crash carts. Full cylinders should be labeled and stored away from empty ones to avoid confusion. Though respiratory therapy routinely changes cylinders in hospitals, nurses may be required to do so. The nurse should be properly trained before attempting to perform this task. Nurses preparing patients on oxygen therapy for transport should ensure the portable cylinder has enough oxygen supply for the trip. If the patient is in a long-term healthcare facility, the patient may be making a round trip, like to an appointment and back. The tank should have enough supply to accommodate both trips. In the home setting, patients and caregivers should have education about fire safety. They should prepare the environment by posting oxygen in use warning signs warning others to refrain from smoking, including e-cigarettes. Fire extinguishers and smoke detectors should be in place and in working order. Oxygen should be kept 6 feet from heat sources or potential sparks, such as open fires, heaters, stoves, and lit candles. Additionally, a 6-foot distance should be kept from toys or appliances with electric motors like hair dryers, electric razors, and toothbrushes. Instructions should also include avoiding the use of aerosol sprays, cleaning products, and using petroleum products like Vaseline around the face. Patients and caregivers should understand how to operate the prescribed device. A flow meter regulates the amount of oxygen that is delivered in liters per minute. The flow meter connects to the oxygen port on the head wall in hospitals and to the tank on e-cylinders. On hospital head walls, the flow meter connects to the head wall port by aligning the pins on the meter with those on the wall socket and pushing in the meter. The flow meter has a green collar which should be twisted before removing the device. The flow meter has a clear cylinder with lines and corresponding numbers which denote the liter per minute of oxygen delivery. A dial is used to increase or decrease the flow. A ball will float up or down. To set the rate, the line which corresponds with the prescribed oxygen rate should be aligned with the middle of the ball in the cylinder. A green adapter is typically located at the bottom of the flow meter for adaptation to various tubings. This adapter is commonly called a Christmas tree. Some humidifiers require the removal of the Christmas tree, and care must be taken to prevent its loss. A good practice is to tape the Christmas tree onto the head wall next to the flow meter. This adapter is required when using emergency equipment such as emergency resuscitation bag valve mask devices or AMBU bags. E-cylinders typically have a flow meter built into the collar that is placed on top of the tank. It may have a floating ball type flow meter, or it may have a dial with numbers denoting the liter per minute. The collar will also have a pressure regulator to enable the user to validate the amount of oxygen available in the tank. A key should be attached which opens and closes the tank. Extension tubing may be required to allow the oxygen delivery device to reach the patient. The patient should have ample room to move around in bed without restriction. Supplemental oxygen delivery devices are classified in one of 3 systems: low flow, reservoir type, and high flow. In this PowerPoint, we will only briefly touch on the purposes of the delivery devices. This will be discussed more thoroughly in your gas exchange lectures and study of exemplars. The flow rate is the number at which the flow meter dial is set. The concentration of oxygen is determined by the type of delivery system, the rate of flow, the correct placement and fit of the delivery device on the patient, and in most cases, the length and depth of inspiration. The concentration percentage given here is presuming correct placement and fit. A nasal cannula is a low-flow system and is a commonly used delivery device. The flow rate for a nasal cannula is between 1 liters per minute and 6 liters per minute. Oxygenation percentages are between 24 and 44% respectively. The percentage of oxygen concentration is increased from that of room air by 4 percentage points for every liter increase. For instance, at a setting of 1 liter per minute by nasal cannula, the patient inspires 24% oxygen. 2 liters per minute gives 28% oxygen. 3 liters per minute gives 32% oxygen, and so on up to 6 liters per minute. Oxygen is delivered by nasal cannula to treat non-critical patients with hypoxia, to oxygenate patients undergoing medical procedures and treatments, and in the long-term treatment for patients with COPD. It can be used for patients who cannot tolerate or use a mask. Nasal cannula is easy to use, inexpensive, and better tolerated than other delivery devices. One advantage is that the patient can talk and eat while wearing a nasal cannula. It can, however, become dislodged easily and irritate the nasal mucosa and skin around the nose, cheeks, and ear. The nurse should routinely assess these areas for skin breakdown. Oxygen by nasal cannula should not be used for patients with nasal obstruction. It should not be used at flow rates higher than 6 liters per minute. Oxygen is very drying, so if the rate of flow is 4 liters per minute or higher, it should be humidified to prevent irritation to the nasal and sinus mucosa. A rate of 2 liters per minute is usually well tolerated by patients with COPD, but higher rates can induce carbon dioxide narcosis. Nasal cannula have 2 prongs which fit in the patient's nares, pointing to the back of the patient's head. The prongs are slightly curved to conform to the shape of the upper lip. The tubing should be looped around the ears. It is then tucked under the chin and secured with an adjustment apparatus. Special cushions are available, or gauze should be used to protect the ears from skin breakdown when used long term. An oxygen-conserving nasal cannula is a reservoir system that delivers oxygen more efficiently than a standard nasal cannula. It conserves oxygen and allows the patient to be well oxygenated at lower flow rates. The reservoir system delivers approximately twice the concentration as compared to a standard nasal cannula. For example, a reservoir nasal cannula setting of 3.5 liters per minute is about the same as 6 liters per minute of a standard nasal cannula. It is used for patients on long-term oxygen therapy at home who require higher flow rates than a standard nasal cannula. The reservoir cannula fits the same as a standard cannula, but has a reservoir that fits below the nose or neck like a mustache or pendant. A simple face mask is a low-flow oxygen system. The flow rate is set at 6 to 12 liters per minute. The rate of flow is higher than that of a nasal cannula to prevent the patient from rebreathing carbon dioxide. This is a very important concept to remember. Setting the flow rate too low causes more harm than good. Simple face masks deliver an estimated 35 to 60% of oxygen depending on the rate of flow and the length and depth of inspiration. An oxygen face mask is used for short periods of time, such as during patient transport or when arousing from an anesthetic. The masks should fit snugly. This may cause some patients to feel claustrophobic. The mask does not need humidification due to the tight seal and heat from the nose and mouth. Simple face masks are contraindicated in patients with carbon dioxide retention. Caution should be used in the patients with severe claustrophobia or injury to the bridge of the nose. A face tent is a good alternative for these patients since the face is partially uncovered. Humidification is necessary with a face tent. The mask is applied over the bridge and nose. A metal strip is located at the top of the mask to help it conform to the bridge of the nose. Holes are located on either side of the mask for exhalation and mixture with room air. An elastic strap goes around the back of the patient's head and should be adjusted on each side for a snug fit. Care should be taken to avoid scratching the patient's eyes when pulling the strap over and around the patient's head. Non- and partial rebreathing masks are reservoir systems. The flow rate should be set from 8 to 15 liters per minute and adjusted to keep the reservoir inflated. These systems deliver higher concentrations of oxygen from 60 to 100%. Non- and partial rebreathing masks are a short-term solution for patients who need higher inspired oxygen, FiO2, or who have an urgent need due to desaturation. This therapy is intended for the short term, less than 24 hours. The reservoir collects oxygen and has a one-way valve which prevents room air and exhaled carbon dioxide from entering. A non-rebreather has flutter valves on the mask which prevent exhaled air and room air from entering the mask. These valves should be checked by the nurse to ensure they remain open on expiration and closed on inspiration. A partial rebreather has one or no flutter valves and allows some exhaled air to enter the mask. Your Lewis text states that some facilities find the partial rebreather mask a safer option. The reservoir should remain inflated to avoid CO2 buildup. The reservoir mask is applied the same as a simple face mask. It is very important to monitor the mask to ensure the reservoir remains inflated and the mask has a snug fit. The patient needing a non or partial rebreathing mask is in a condition which warrants close monitoring, as more advanced treatments may be needed. Venturi or Venti masks are high-flow systems. The flow rate is dependent on the percentage of oxygen ordered and vary according to the manufacturer. The range is approximately 4 to 12 liters per minute for a concentration of 24 to 50%. The mask has an air entrapment device which mixes room air with oxygen to deliver a precise concentration of oxygen. The nurse should consult the manufacturer's instructions to find the appropriate flow rate for the ordered percentage. Some Venturi masks have color-coded entrapments in assorted percentages with the flow rate or liters per minute setting embossed on the side. These entrapments are attached to the tubing of the mask. Manufacturers of other masks have the entrapment in a dial which can be turned to various percentages. Venturi masks deliver a precise concentration of oxygen and intended to be used for patients with CO2 retention, such as those with COPD. It allows a low concentration of oxygen to be delivered with minimal CO2 buildup. Typically, the percentages settings are 24, 28, 31, 40, and 50%. The nurse should ensure the air entrapment device is not occluded. Sometimes patients can no longer maintain an airway or require support with ventilation when they undergo surgical procedures or have severe respiratory problems. Advanced airways are inserted in the form of endotracheal tubes and tracheal tubes. Endotracheal tubes are inserted through the mouth, or less frequently the nose, and end in the trachea. They are usually inserted first and are temporary. Injury to the larynx and trachea, such as erosion, can occur due to pressure from the tube and inflation cuff. The goal of these tubes is to support the patient until they can breathe on their own and maintain a patent airway. If the tube must remain longer than 7 to 21 days, a tracheostomy is performed. Tracheal tubes are inserted directly into the trachea. Adjustments to artificial airways cannot be delegated. Oxygen may be provided to these tubes in a variety of ways. If the patient needs to be ventilated, the tube is connected to a manual resuscitation bag, which will be discussed later in this PowerPoint, or an automatic ventilator, which will be discussed in future courses. If the patient is breathing on their own, a T-tube, also called a T-piece, or tracheal collar is used. Since these tubes bypass the normal nasal and oral airways, humidification of oxygen is always required. The T-tube is a T-shaped piece which connects from a humidified oxygen source to the endotracheal or tracheal tube using a large bore tubing. A shorter large bore tubing on the other side of the T-tube acts as a reservoir. The flow rate is set at 10 liters per minute. The nurse should monitor to ensure the tubing does not pull on the tube, as this may put undue pressure on the mucosa or dislodge the tube. The tracheal mask or collar centers over the trach tube with an elastic strap and wraps around the patient's neck. A large bore tubing is connected to a humidified oxygen source. Flow rate and percentage of oxygen operates the same as a face mask. Humidification may cause water to collect around the mask or the tubing, and the nurse should disconnect and discard as needed. Manual resuscitation bags, or bag valve mask devices, are used to manually ventilate patients. They are commonly referred to as AMBU bags. Emergency carts and high-risk areas such as emergency rooms, intensive care units, and recovery rooms have AMBU bags immediately available. The device is a high-flow device with a flow rate set at 15 liters per minute. The bag is available in infant, child, and adult sizes, which provide appropriate tidal volume for each age group. Included with the bag is a connector for attachment to endotracheal and tracheal tubes, as well as to a face mask. The mask has a soft air-filled cushion to help maintain an airtight seal around the nose and mouth to ensure adequate ventilation. Tubing on the bag connects to an oxygen supply. The bag is self-inflating and has a one-way valve which allows oxygen from the bag to enter the mask and permits reinflation of the bag. The operator of the AMBU bag should be situated at the head of the patient. The mask fits over the bridge of the patient's nose and around the mouth. The operator should hold the mask in the non-dominant hand and the bag in the dominant hand. The user's index finger and thumb should form a C around the top of the mask. The remaining 3 fingers should hook the mandible and assist in lifting the jaw to maintain a patent airway. The user should squeeze the bag to deliver a breath to the patient according to American Heart Association guidelines. Sometimes patients cannot keep their airway open or patent. This may be due to effects of medications like sedatives or from a semi or unconscious state. The insertion of oral or nasal airways cannot be delegated. Oropharyngeal airways are used to maintain a patent or open airway in an unconscious patient or one without a gag reflex. The airway is made of a hard plastic material and is C-shaped. It has a phalanged end, which rests against the teeth, and a distal end, which sits in the oral pharynx. A patient with an intact gag reflex will not be able to tolerate this type of airway. The oral airway is either marked with a size number or in millimeters. Sizes range from 000 for neonates, which is 30 millimeters, to a size 6, which is 100 millimeters and used for a large adult. To measure the patient for the correct size, place the airway at the mouth opening, against the cheek, to the jawline where the tip should reach. A tongue blade should, ideally, be used to depress the back of the tongue during insertion. To begin insertion, the curved end of the oral airway should be pointing up toward the palate. Halfway through insertion, or at the back of the throat, the airway should be rotated 180 degrees. This helps prevent the airway from pushing the back of the tongue into the pharynx and furthering or creating an obstruction. Nasopharyngeal airways are used for conscious, semi-conscious, or unconscious patients with intact cough and gag reflexes, to help maintain an adequate airway, and for those requiring frequent suctioning. It is made of soft rubber or silicone, which does not promote gagging when in the pharynx. The tube is curved with a flange on one end and a beveled end on the other. Nasal airways use French sizes with the internal and external dimensions noted. Sizes range from 12 French to 38 French. To determine the appropriate size, use the smallest finger of the patient as a guide. The length should be determined by measuring against the face. The tube should measure from the tip of the nose to the tragus of the ear plus 1 inch. Insert the nasal airway into the largest nostril, typically the right. The tube should be lubricated with a water-soluble lubricant. The bevel of the tube should be on the same side as the septum. Pass the tube gently in a posterior direction along the plane of the face. If resistance is encountered, rotate the tube. If this does not help, attempt placement in the other nostril. Incentive spirometry helps patients breathe better by providing visual encouragement or incentive for taking deep, slow breaths. Taking deep, slow breaths, along with forceful coughing and early mobility, reduce the risk of pulmonary complications such as atelectasis. There are 2 types of incentive spirometer. One type, flow-oriented incentive spirometer, has 1 or more chambers with free-floating ball or balls. The patient is encouraged to keep the ball elevated for as long as possible to keep the lungs expanded. The other type of spirometer is volume-oriented. This type has bellows which inflate to a preset number to give the patient a visible goal to achieve. Helping patients use incentive spirometers may be delegated to a nursing assistant. The assessment, monitoring, and evaluation of the use of the spirometer is the responsibility of the RN. Patient education and the use and evaluation of the teaching is also the responsibility of the nurse. To use the incentive spirometer, the patient should sit upright and exhale completely through the mouth. The patient should then inhale slowly and deeply with lips tight around the mouthpiece. The patient should then hold their breath for 3 seconds before exhaling. The ball or bellow should rise with inspiration. The patient should take up to 30 breaths with 30 to 60-second rest periods between sets of 10. If a patient cannot reach the targeted volume, they should be encouraged to use the spirometer more frequently. Oxygen is absorbed by hemoglobin and transported to cells by arterial blood. The amount of oxygen saturated in arterial blood is denoted by the abbreviation SaO2. This measurement can be obtained by drawing blood from an artery for measurement of arterial blood gases, or ABGs. A second method is by placing a sensor clip on the patient for an electronic reading or pulse oximetry. Measurements taken from pulse oximetry are written SpO2. Readings vary, but normal readings range from 94 to 100%. In most patients, readings below 90 to 92% are cause for concern. Pulse oximetry works by shining 2 light-detecting diodes, one red and one infrared, through a vascular area such as the fingertip, toe, or earlobe using a sensor or probe. A light-sensing detector on the other side of the probe picks up the light as it passes through the arterial and venous system. Oxygenated hemoglobin in the artery absorbs more infrared light. Deoxygenated hemoglobin in the venous system absorbs more red light. By comparing the two, the oximeter determines the amount of oxygen saturated. This process takes 3 to 10 seconds, so is not immediate, but desaturation is noted faster by pulse oximetry than by clinical observation. Several factors can affect the accuracy of the reading. Anemia, or a decreased amount of hemoglobin, can indicate a reading within normal limits, but there may not be enough saturated hemoglobin to reach and oxygenate the tissues. In carbon monoxide poisoning, CO2 instead of O2 is absorbed by the hemoglobin and renders it non-functioning. Pulse oximeters assume all hemoglobin is saturated with oxygen and deliver inaccurate results for non-functioning hemoglobin. Some dyes, such as methylene blue or indigo carmine, when injected into the bloodstream during procedures, can affect light transmission and alter results. Probe placement can also affect the results. The probe must be placed on a pulsatile vascular area such as the fingertip, toe, earlobe, or bridge of the nose. The fingertip is shown to have the most accurate results, but may be difficult in patients with excessive movement. This movement can produce artifact, which can give false readings. Infants and children tolerate fingertip placement poorly. Flexible probes on the toe, foot, or palm of the hand are better options. For sedated patients, a good practice is to use the third or little finger for placement, as people tend to rub their eyes when waking up and can scratch the cornea. Certain nail polish colors or artificial nails can impede light detection. Blue, green, black, and some red or brown polish may need to be removed, or the sensor may need to be placed sideways on the finger. Circumstances which impede pulsation or blood flow can interfere with the reading. Pulse oximeter probes should be placed on the opposite extremity from the blood pressure cuff or tourniquet. If the finger is placed too far into a clip-style probe, venous pulsation can occur, which mimics arterial pulsation and will produce inaccurate results. Remember that SpO2 measurement alone is not enough to evaluate the status of all patients. Those with problems of inadequate ventilation, acid-base abnormalities, hypotension, or vasoconstriction can have inaccurate SpO2 readings. There is an adage you will hear quite often in nursing: treat the patient, not the machine. If the saturation goes down, look at the patient. Are they having difficulty breathing? What is their color? Do a respiratory assessment. Pulse oximetry is a valuable tool, but only one of many tools used by the nurse in assessing the patient.